Hello everyone, my name is Dr. David Francic. I'm a physician partner at Family Practice Specialists and IntraCare Health Center in North Phoenix. Here I've had the privilege of practicing medicine for the past 18 years. I completed my medical training at Arizona College of Osteopathic Medicine, AZCOM, and went on to complete my residency at St. Joseph's Hospital Medical Center. In addition to my clinical work, I am a clinical associate professor at AZCOM, helping to train the next generation of osteopathic physicians. I am also a principal investigator for Helios Clinical Research, where I've overseen more than 50 clinical trials across a wide range of therapeutic areas. As many of you know, IntraCare, in collaboration with Alliance Medical Partners, recently introduced new ancillary services to our clinics. However, there's been a fair amount of confusion and, frankly, skepticism about what these services are for and how they fit into our day-to-day practice. Some of my colleagues have questioned whether these tests are useful, or whether they're just gimmicks, a waste of resources, or simply a revenue-generating tool. Many felt unsure about ordering them, and when they did, they were not confident interpreting the results. And understandably, no one wants to feel uncertain in front of their patients. So I decided to take a closer look for myself. I figured if insurers are covering these tests, there must be some clinical value behind them, or they would not cover them. I started by looking at the ANS pseudomotor test. At first glance, it might seem like it's just telling you about a patient's stress levels or functional age, but that's not the real purpose. What this test is evaluating is the autonomic regulation of the heart. As I dug deeper, I found that it's primarily designed to detect a condition called cardiac autonomic neuropathy, or CAN. To be honest, I hadn't even heard of the term cardiac autonomic neuropathy until recently. I was vaguely familiar with autonomic dysfunction, but my understanding was limited. And like many of you, I had never been taught to routinely screen for it in clinical practice. So today I want to talk with you about the cardiac autonomic neuropathy, what it is, why it matters, how we can diagnose it, and how this new testing can actually help us care for our patients in a more proactive and evidence-based way. Cardiac autonomic neuropathy, or CAN, results from damage to the autonomic nerve fibers that regulate cardiovascular function. This damage impairs both sympathetic and parasympathetic control of the heart and blood vessels, leading to reduced heart rate variability, abnormal vascular responses, and a significantly increased risk of cardiovascular events. Major risk factors for CAN include hyperglycemia, hypertension, dyslipidemia, obesity, and the presence of other microvascular complications. CAN is a serious and under-recognized complication in patients with type 2 diabetes. It is especially prevalent in those with long-standing disease or poor metabolic control. As the condition progresses, CAN leads to symptoms such as exercise intolerance, orthostatic hypotension, and resting tachycardia, which can significantly impact quality of life. More importantly, CAN substantially increases the risk of arrhythmias, silent myocardial ischemia, and sudden cardiac death. It is also a strong independent predictor of cardiovascular morbidity and mortality. In fact, diabetic patients with CAN have up to a 5-fold increased risk of cardiovascular death, making it one of the most serious yet frequently overlooked complications of diabetes. Unfortunately, despite its significance, CAN remains widely under-recognized in clinical practice. As highlighted in a 2025 study published in BMC Endocrine Disorders by Rajay and colleagues, CAN is an underdiagnosed complication of type 2 diabetes and a predictor of mortality and cardiovascular morbidity. Hence, CAN screening is essential. The prevalence of CAN in patients with diabetes varies widely, ranging from about 2% in newly diagnosed or well-controlled patients to as high as 60% in those with long-standing diabetes. The risk increases with the duration of diabetes, and those with poor glycemic control or other metabolic complications are especially vulnerable. However, CAN doesn't just show up late in the disease. It can also occur early in the course of diabetes, and in some cases even before diabetes is formally diagnosed, particularly in individuals with impaired glucose tolerance. Despite this, CAN is frequently underdiagnosed, largely because of its subtle onset and nonspecific symptoms, which are often attributed to other more common conditions. While diabetes is the most well-known cause, CAN is not limited to diabetic patients. It's also seen in neurodegenerative diseases like Parkinson's disease and multiple system atrophy, where autonomic dysfunction is a common and expected feature. In these populations, can be just as impactful, contributing to increased morbidity and mortality. We also see CAN in patients with chronic renal failure, amyloidosis, and in those undergoing certain chemotherapies. So while diabetes may be the most familiar context, the epidemiological footprint of CAN is actually much broader than we tend to recognize.
As you can see in this figure, the pathophysiology of neuropathy is complex, but at its core, it is driven by the convergence of metabolic and inflammatory pathways associated with hyperglycemia and dyslipidemia. Hyperglycemia increases glucose flux through several damaging pathways, including the formation of advanced glycation end products, or AGEs. These AGEs interact with receptors such as RAGE and LOX1, and together with AGE-modified LDL, set off inflammatory signaling cascades. In addition, excess glucose activates the hexosamine and polyol pathways, leading to osmotic stress and increased production of reactive oxygen species, or ROS, through NADPH oxidase and mitochondrial dysfunction. The resulting oxidative stress causes DNA damage and endoplasmic reticulum stress, ultimately leading to apoptosis in neurons, glial cells, and vascular endothelial cells. Dyslipidemia further contributes to cellular injury through elevated triglycerides, LDL, and free fatty acids, as well as reduced HDL. Oxidized LDL and oxysterols activate TLR4 and other inflammatory pathways, while impaired insulin signaling, primarily through disruptions in the PI3K-AKT pathway, results in a loss of neurotrophic support. Insulin resistance and reduced C-peptide levels further compromise neuronal health. Persistent macrophage activation sustains a pro-inflammatory environment, amplifying nerve injury. Altogether, these mechanisms disrupt normal nerve function and drive the progressive degeneration seen in neuropathy.
This figure illustrates the progression of CAN over time. In the early stages, parasympathetic dysfunction is typically the first to appear. Patients may exhibit reduced heart rate variability and resting tachycardia, often ranging from 100 to 130 beats per minute. This early loss of vagal tone leads to a relatively fixed heart rate and diminished exercise intolerance, increasing the risk for arrhythmias. As the disease advances, sympathetic denervation begins to emerge. Some patients develop orthostatic hypotension, marked by a significant drop in blood pressure upon standing, often accompanied by dizziness, lightheadedness, or syncope. Importantly, abnormalities in heart rate variability and barrel reflex sensitivity can often be detected through autonomic testing before clinical symptoms are evident, allowing for earlier diagnosis. In more advanced stages, further sympathetic impairment results in greater hemodynamic instability and increases the risk for silent myocardial ischemia or infarction due to impaired pain perception. In some cases, bradycardia may develop as sympathetic input to the heart continues to decline.
I want to pause for a moment to share an observation I've made in my own practice, and one that has been echoed by many of my colleagues. We've seen a noticeable rise in autonomic dysfunction following COVID-19, including features consistent with CAN. While COVID-19 is best known for its respiratory effects, a significant number of patients continue to experience lingering symptoms that point to autonomic involvement. As described in a 2022 article by Cordova Martinez and colleagues in Biomedicines, the primary mechanism of peripheral neuropathy in COVID-19 is immune-mediated and inflammatory damage, particularly related to cytokine release and autoimmune responses such as molecular mimicry. The authors also note that histopathologic evidence supports an inflammatory cause rather than direct viral invasion of nerve tissue. Clinically, these patients often present with resting tachycardia, orthostatic intolerance, fatigue, and exercise intolerance, symptoms that overlap significantly with CAN. Autonomic testing may reveal reduced heart rate variability and impaired barrel reflex sensitivity, or findings consistent with post-viral autonomic dysfunction. As our understanding of long COVID evolves, it's important to consider CAN as part of the broader spectrum of post-COVID complications, allowing for earlier recognition and more targeted management. Which brings us to screening. CAN is often diagnosed after significant glycemic damage has occurred, but early screening using cardiovascular reflex testing can help prevent serious complications.
The American Diabetic Association 2025 CAN screening recommendations are as follows. For patients with type 1 diabetes mellitus, screening should begin 5 years after diagnosis. When those with type 2 diabetes mellitus should begin screening at the time of diagnosis. To screen, the clinician should ask about symptoms that suggest parasympathetic dysfunction, such as dizziness or syncope, but also microvascular dysfunction, such as erectile dysfunction. Look for resting tachycardia, orthostatic hypotension, and so forth. You should consider screening patients with poor glycemic control that are at increased risk for developing diabetic complications, including CAN. Additionally, patients presenting with symptoms suggestive of autonomic dysfunction should be screened. These symptoms may include unexplained resting tachycardia, exercise intolerance, orthostatic hypotension, gastrointestinal symptoms, which can include gastroparesis, idiopathic diarrhea or constipation, abdominal pain or discomfort, dysphagia. Furthermore, patients with other microvascular complications such as retinopathy and nephropathy are at a higher risk for CAN. Diagnosis typically involves clinical symptoms and cardiovascular autonomic reflex tests, or CARTs, which are considered the gold standard for diagnosing CAN. CARTs are standardized assessments used to evaluate the integrity of the autonomic nervous system's control over heart rate and blood pressure. The most widely used protocol is Ewing's battery of 5 standard cardiovascular reflex tests, which include heart rate response to deep breathing, or the E to I ratio. Assess the parasympathetic function by measuring the difference in heart rate during inspiration and expiration. Heart rate response to standing, or the K30-15 ratio, evaluates parasympathetic function by calculating the ratio of the longest RR interval around the 30th beat to the shortest around the 15th beat after standing from a supine position. The Valsalva maneuver assesses parasympathetic function by measuring heart rate changes during and after forced expiration against a closed airway. Blood pressure response to standing evaluates sympathetic function by measuring the drop in systolic blood pressure upon standing. And blood pressure response to sustained hand grip assesses sympathetic function by measuring the increase in diastolic blood pressure during sustained isometric exercise, such as the hand grip. In summary, heart rate-based tests such as those involving deep breathing, the Valsalva maneuver, and the heart rate response to standing primarily reflect parasympathetic or vagal function. These tests are sensitive indicators of early autonomic dysfunction. In contrast, blood pressure-based tests, including the blood pressure response to standing and sustained hand grip, primarily assess sympathetic function and are more specific for detecting advanced stages of CAN. The sensitivity and specificity of these tests are high, especially when 2 or more are abnormal. Additional testing for CAN includes heart rate variability analysis, which is a non-invasive and objective method to assess autonomic function and is commonly used in both clinical and research settings. Pseudomotor function tests assess sweat gland innervation, can be useful for early detection. Cold face stimulus tests assess autonomic reactivity by applying a cold stimulus to the face and observing cardiovascular responses. And the barrel reflex sensitivity combines heart rate and blood pressure data to assess barrel reflex function. The Toronto Consensus Panel defines the stages of CAN. 1 abnormal CART result suggests possible or early CAN. 2 or more abnormal CART results suggest definite CAN, but if orthostatic hypotension is present, then this could suggest severe or advanced CAN. Now, as you know, the system we have been previously using to perform CARTs generated a report that was burdensome and too difficult to interpret, not just for us providers, but for staff and patients as well. Recognizing the need for something more clinically useful, Alliance Medical Partners, AMP, identified a system that delivers not only a more accurate report, but also one that is straightforward and easy to read. I have personally reviewed this system and will share my findings with you today. AMP has since purchased the Flow 7 CCS Cloud, and we will be implementing this system going forward in our clinic. The Flow 7 CCS Cloud, which I've depicted here, performs 3 key diagnostic tests. First, TBL-ABI, toe brachial index, ankle brachial index. This is a rapid, non-invasive screening tool for peripheral artery disease. It combines standard ABI measurement with pulse volume plethysmography, or PVP, which evaluates blood flow quality by detecting volume changes in the arteries with each cardiac cycle. The waveform morphology is categorized as triphasic, biphasic, or monophasic, helping to localize and characterize your vascular impairment. Number 2 is the sweat-C, or the electrochemical sweat conductance. This test measures sweat gland conductance and reflects the function of small autonomic nerve fibers, particularly those involved in pseudomotor activity. It's a sensitive marker for small fiber neuropathy and microvascular dysfunction, often present in early diabetes, metabolic syndrome, and autonomic disorders. The last test is the OXY-W, or oxidative stress index waveform. This component analyzes pulse waveform morphology using plethysmography at the finger or toe to assess vascular oxidative stress, microvascular tone, and heart rate variability. It can also be used in conjunction with Ewing's test protocols to evaluate cardiovagal function and autonomic balance, making it a valuable tool in assessing early cardiovascular risk. As you can see here, I have compared the sensitivity and specificity data for the Flow7 against other tests such as the Ewing battery of tests, heart rate variability, pseudomotor function test, quantitative sweat test, and the traditional tilt table test. You can see that the sensitivity and specificity for the Flow7 is 88 to 92% and 80 to 97% respectively, which is a result of using a combination of CARTS, heart rate variability, pseudomotor, and PTG analysis. In contrast, the tilt table test has a sensitivity of 60 to 80% and specificity of 70 to 85%. Traditionally, we would wait until our patient has symptoms of orthostatic hypotension before sending them to the cardiologist to perform a tilt table test. But as you have learned, if the patient has CAN, we are waiting to diagnose them after they have developed advanced disease. The Flow7 enables us to screen our patients much sooner and perhaps enable us to alter the course of the disease. I'm going to go through each report, but I want to start with the oxidative stress index waveform because this is the test you will be using to screen and/or diagnose your patient with CAN. Here is the report, and you can see that it is only 2 pages and not 50 pages like the previous system report. Highlighted here are the findings for the HRV analysis, the CARTS, parasympathetic responses, and the CARTS sympathetic responses. The first analysis depicted here is the heart rate variability using markers for total power and SDANN or SDAN. Conveniently, the report defines each marker for you before providing the result and reference range. However, I'd like to go through each measurement with you. Total power is determined by summing the energy in the very low frequency, and high frequency bands during the measurement window of 2 minutes. It serves as a comprehensive measurement of heart rate variability, reflecting the combined effects of both sympathetic and parasympathetic nervous system activity on cardiac function. Typically, higher total power is linked to greater autonomic flexibility and better cardiovascular health, whereas lower total power is observed in various disease states such as heart failure, myocardial infarction, and stroke, and is considered an adverse prognostic indicator. Normal total power is greater than 1200 units, so as you can see, the individual has a low total power. SDAN, or the standard deviation of the average normal to normal intervals, is a heart rate variability metric that reflects longer-term autonomic trends. It is calculated by taking the standard deviation of the average normal to normal intervals over multiple 2-minute segments throughout the monitoring period. This measurement is particularly valuable for detecting slower fluctuations in autonomic tone, which are influenced by factors such as circadian rhythms, sleep-wake cycles, and other long-duration physiological changes. By evaluating the variability across these extended periods, SDAN offers insights into the overall balance and adaptability of the autonomic nervous system. Normal SDAN is greater than 40 units, so this individual also has a low SDAN. Next are the CARTs, which they have divided into the parasympathetic and sympathetic response for us. In this individual, she has a normal Valsalva and EI ratio, but her K30-15 ratio is borderline high, which could suggest she has a strong parasympathetic tone. If she has symptoms of bradycardia or dizziness, this could be worrisome for an autonomic imbalance. If it was low, however, then it would suggest loss of parasympathetic tone consistent with CAN. When looking at the sympathetic response, the first measure is the change in systolic pressure response to standing, which is an estimation of the norepinephrine response. An exaggerated increase of 10 millimeters of mercury is linked to sympathoadrenergic hyperactivity and a higher risk of major adverse cardiovascular events. A decrease of 20 millimeters of mercury is a diagnostic for orthostatic hypotension and may cause symptoms like dizziness or syncope. The second measurement, the change in diastolic pressure response to standing, is an estimation of the epinephrine response. You can see that both of these measurements are normal in this individual. The next highlighted section is the interpretation. In this case, on the HRV analysis, her total power was borderline, suggesting reduced autonomic flexibility, and her S-stand is borderline, suggesting early or mild CAN. Notice the report states that there is a possibility of exercise intolerance, as this is an early sign of CAN. The carts demonstrated that she had a normal Valsalva and EI ratio, but borderline high K30-15 ratio, suggesting possible autonomic imbalance. Her change in systolic pressure and diastolic pressure response to standing were normal. So, because of the abnormal HRV, it suggests she may have the early stages of CAN, not late. The next report is the SWET-C or pseudomotor function report. Just like the previous report, the markers, results, and ranges are provided in one place for easy interpretation. Also, if you look below the highlighted box, you can see that each marker is clearly defined for you. The first marker, or the sweat peak, is measured from the peak amplitude of the galvanic skin response at the positive electrode. It estimates the amount of sweat produced. A low or absent sweat peak may suggest a disorder affecting the postganglionic pseudomotor nerves, commonly seen in peripheral neuropathy. Her result is greater than 1100 units, however, suggesting hyperhidrosis. The next marker, the nitric oxide, or NO peak, is measured from the peak amplitude of the galvanic skin response at the negative electrode. It estimates the vasodilatory response of the postganglionic cholinergic sympathetic nerves when stimulated. The NO peak is linked to microcirculatory markers, offering insight into the vascular aspects of autonomic dysfunction. Her result is normal. Next is latency, which is the time taken for a response to appear after a stimulus, indicating the speed of nerve conduction. Prolonged latency can suggest pseudomotor dysfunction, possibly due to small fiber neuropathy, as it indicates delayed nerve conduction. Her result is normal. Last is the delta percent foot, which is the percentage difference in response between the right and left feet. A significant delta percent indicates asymmetry, which may point to focal or asymmetric neuropathic conditions such as localized nerve injury or early neuropathy. Her result is normal. Next section is the interpretation. In this case, there is a robust sweat peak which may indicate hyperhidrosis, a form of autonomic dysfunction involving an exaggerated sympathetic response to stimuli. The report also notes signs of C fiber inflammation, which is consistent with small fiber neuropathy. C fibers are unmyelinated nerve fibers involved in the sympathetic and parasympathetic nervous systems, helping to regulate sweating or pseudomotor function, vascular tone, and heart rate variability. Because of their small diameter and lack of myelination, C fibers are particularly susceptible to damage from conditions such as diabetes, long COVID, and autoimmune diseases. When affected, patients may experience symptoms of small fiber neuropathy or broader autonomic dysfunction, including abnormal sweating, orthostatic intolerance, and neuropathic pain. The last report is the TBL-ABI report. Unlike the other two reports, it is 3 pages. Again, in order to determine the presence of peripheral artery disease, it combines the standard ABI measurement with pulse volume plethysmography, or PVP. As in the other reports, I have highlighted the results here. The first measurement is the ankle brachial index, or ABI, which has a specificity and sensitivity of 77.8%. The reference range can be seen below. An ABI range between 1 and 1.3 is normal, or NR. Between 0.9 and 1 is acceptable, or AC. Between 0.8 and 0.9 is borderline, or B. Between 0.6 and 0.8 is definite, or D. This suggests that there is definite peripheral artery disease. Less than 0.6 is severe, or S, meaning severe peripheral artery disease. Going in the other direction, if the range is between 1.3 and 1.39, that is pre-non-compressible, or PNC, suggesting that the artery is stiff. If the range is greater than or equal to 1.4, then the artery is non-compressible, or NC. The toe brachial index, TBI, has a specificity of 55.6%, but a sensitivity of 100%. The reference range for TBI is similar to that of the ABI range, in that it can be normal, acceptable, borderline, definite, or severe. SBI is the sum of the overall ABI and TBI and has a specificity of 88.9% and sensitivity of 100%. Therefore, it is more accurate than either the ABI or TBI alone. But if the ABI is greater than or equal to 1.4, the SBI is not valid. Instead, the use of the vasomotion toe photoplethysmography index is an alternative, which we will discuss when we review page 2 of the report. The reference range for SBI is shown below. Page 2 of the report displays the PVP recordings of the arms, dorsalis pedis artery, posterior tibial artery, and vasomotion toe photoplethysmography. Also shown is the vasomotion toe photoplethysmography index, which we will be using if the ABI is greater than or equal to 1.4. To understand this section of the report, first we must understand the morphology of the waveforms and what they mean. The first waveform is the triphasic waveform, which has a peak with a negative return and a positive bounce. Triphasic waveforms are normal and represents healthy arterial flow. Next is the biphasic waveform, which has a peak and negative return but no bounce. The presence of biphasic waveforms suggests mild to moderate atherosclerosis. Last are monophasic waveforms, which is a peak without a negative return and no bounce. If monophasic waveforms are seen, they indicate greater than or equal to 50% stenosis and likely PAD. When we go back to the report and analyze the morphology of these waveforms, you can see that they are triphasic because they have a peak followed by a negative return and bounce. Next is the toe photoplethysmography, or PTG, waveforms. Seen here are the 4 types indicating the stiffness of the artery. Type 1 has a clear dicrotic notch with a bounce, which is normal. Type 2 has a clear dicrotic notch without a bounce and suggests borderline stiffness. Type 3 does not have a clear dicrotic notch and suggests moderate stiffness. And type 4 has no dicrotic notch and indicates severe stiffness. On the left of the report is the toe PTG. You can see that the waveforms have a dicrotic notch and a bounce, suggesting these waves are type 1 or normal. On the right is the vasomotion toe PTG index, or PTGI, which refers to the spontaneous rhythmic fluctuations in blood vessel diameter, specifically arterioles and capillaries, in the toes as observed using PTG. The less vasomotion that is observed, the lower the PTG index and may indicate peripheral artery disease with a specificity of 83.3% and a sensitivity of 100%. On page 3 of the report is the interpretation. Here you can see that the interpretation of each measurement is normal. Next, I'll show you an example of an abnormal report. The report is in a little different format, but you can see that his right ABI is 1.83 and the left ABI is 1.68, suggesting the arteries are not compressible. His right TBI is 0.44 and left is 0.49, which, if you remember, is borderline. Because the arteries are not compressible, you cannot use the SBI. The PVP waveforms are biphasic, suggesting moderate atherosclerosis, and the toe PTG is type 3, supporting moderate arterial stiffness. However, the basal motion PTGI is very low. Right is 12.7 and left is 14.8. This suggests that he has severe arterial disease. If symptomatic, he should be referred to vascular surgery for further evaluation. Now that we finally understand these reports, let's discuss treatment strategies. Management primarily involves optimizing glycemic control, managing blood pressure and lipid levels, and addressing lifestyle factors to reduce cardiovascular risk. Lifestyle modifications include diet and exercise are fundamental in reducing risk factors and enhancing vascular function. Intensive glycemic control is crucial for minimizing hyperglycemia-induced nerve damage. Managing dyslipidemia by lowering atherogenic lipids help reduce vascular injury and support autonomic function. Finally, and maybe most importantly, is education. By educating these patients on the disease, signs, and symptoms, as well as the fact that their lifestyle choices can significantly decrease or arrest the progression of this disease, can improve outcome. The awareness of the disease in its early stages so as to give time to alter course can decrease morbidity and mortality for these patients. Pharmacological interventions to improve autonomic function and hemodynamic stability include ACE inhibitors, ramipril and allopril, and angiotensin receptor blockers such as losartan. These agents reduce vasoconstriction and promote vasodilation by inhibiting the renin-angiotensin-aldosterone system, thereby improving autonomic balance and reducing afterload. Beta blockers, such as metoprolol, decrease sympathetic tone, lowering heart rate and reducing myocardial oxygen demand. Beta blockers help restore autonomic equilibrium and protect against arrhythmias. Alpha-1 agonists, such as midodrine, these drugs increase peripheral vascular resistance through vasoconstriction, thereby improving blood pressure and counteracting orthostatic hypotension. And lastly, mineralocorticoids, such as fludrocortisone, agents that enhance sodium and water retention, expanding plasma volume and improving orthostatic tolerance. Antioxidants like alpha-lipoic acid and vitamin E reduce oxidative stress and improve nerve function. Omega-3 PUFAs support autonomic regulation by reducing inflammation and improving endothelial function. A placebo-controlled double-blind trial conducted by DeDangelis and colleagues in 2020 demonstrated improvement in all endpoints after 12 months of supplementing with vitamin B12, 250 micrograms, alpha-lipoic acid, 570 milligrams, acetyl L-carnitine, 300 milligrams, and superoxide dismutase, 10 milligrams. Combination therapies synergistically enhance nerve repair and reduce oxidative stress. In severe cases of CAN with symptomatic bradycardia or heart block, pacemaker replacement is necessary to help to maintain adequate heart rate and improve quality of life. This concludes our discussion on cardiovascular autonomic neuropathy. I hope the objectives were met and that you now feel confident explaining what CAN is, why early screening and diagnosis are critical, and how its course may be altered through targeted interventions. I also hope you feel more comfortable interpreting reports generated from the Flow 7 CCS cloud system. Personally, I now understand how this ancillary service integrates into my practice, and I hope you do too. Thank you for your attention throughout this presentation. I've included many references for your review, and if you have any questions, please feel free to reach out. I'll do my best to answer them. Goodbye.